Well, we'll begin tonight, starting in session two. It's great to have you all back with us. Thank you for joining us yesterday for our first session, where we covered basically our fundamentals of why we visit. And we began with sharing with you a little bit about compassionate community care, why it's important that you care for your own, meaning the people in your close innermost circle. And then we drew into our training, wherein we talked a little bit about the human needs, visiting advice, and then we concluded with tips in terms of the My Story program and approach. Yesterday, we reviewed this. Our human needs are fundamentally all the same, regardless of your culture, background, ethnicity, age, capacity, or capability. We all have the same basic fundamental needs, which include our physical, mental, social, and spiritual needs. And ultimately, that makes a big difference of when we're starting to visit with someone. You want to, encompass the whole person, and you're looking at the entire person. So you're ensuring that you're looking at all those needs, making sure they're fulfilled in whatever way you can. And so it's very important to participate in that way when you're meeting with someone. Then we touched a little bit about visiting advice, and then finally why the My Story matters. And so for any of you that are interested in getting a copy of these resources, we're very happy to provide them to you. I'm going to put a little link here in our chat. And so you can reflect on the actual manual. There's a manual link, which is what we're quoting you from today. All of our training that we say and speak out verbally is actually within the manual itself, and it has more detail in the manual, so you can reflect on that and review it anytime. You all have the copy now, and or you can get a physical copy. So if you wanted a book, an actual hard copy version, feel free to reach out to us. You can email me, or you can call the office, and we can send them your way. Okay. And so we touched on a little bit about the My Story. And the My Story, how it impacts the visiting experience is that it goes deeper. And so you have a chance and opportunity to actually, course, speak to the person and interview them. And it's a form of reminiscent therapy. It's excellent. I highly recommend it for any of you who've had a chance to interview your parents, if they're still with you, or perhaps a sibling or another relative, family member, or a dear friend. It is an incredible opportunity. I'll bring this up really quick. We had a lady who contacted us because her grandmother, who really raised her mother wasn't really in her life. She was more absent, but her grandmother actually essentially raised this young woman, a friend of mine. And so when her grandmother was approaching end of life, she was given a diagnosis of dementia, and she soon started to forget things, obviously. And as part of that, my friend actually reached out and said, "Hey, is there any chance you could send me one of your workbooks?" And so she could actually interview her grandmother before, obviously, her mental state changed and worsened. And so she was able to do that. And she was so grateful for that opportunity because Our Story, which is the My Story workbook, it captures the memories of the person as they go from obviously birth to adulthood. And so it's a wonderful opportunity, and I highly encourage you to try it if you haven't done it already. Now, so today we're going to focus on three new areas. One is communicating with people with disabilities, and I'll touch on that. And then Alex will begin the second and third session, which will conclude in the evening with a little overview of some of the opportunities we have with patient advocacy and then elder abuse. And so when we're speaking about communicating with people with disabilities, it's really important to keep in mind some of these tips. One thing, and most importantly, is that we don't want to make any decisions for anyone. Okay, can you just give me a heads up or finger thumb if you're okay to hear me? Yeah. Okay. Great. Wonderful. So we ask this because oftentimes, the ability to communicate effectively is very important, right? And so it has to be taken seriously. And so when we're talking with people, we want to make sure that we're including them so they're participating in the activity. And so we want to make sure you're speaking directly to the individual. Again, if there's a person who's interpreting for them, you can speak to that individual, obviously as needed, but what you're actually doing is speaking to the person or patient that you're visiting. So you're speaking directly to that individual, okay? And avoid, of course, any disempowering words. We touched on this yesterday, but really things like, victim or sufferer, all of those negative meaning words are actually what you want to avoid. And you want to use positive language. If someone happens to be have blind, part of that condition or blindness, you want to maybe mention that they have a person with a vision impairment, right? So you don't want to completely, define a person by what their condition is. And so you want to avoid any kind of disempowering words. If you are speaking about them in a positive way, it obviously is going to give them an opportunity. It's showing that you care, you're positive towards them, and it's the best way to approach any type of discussion. Be sensitive about physical contact. Now, yesterday we did mention this, that if you're comfortable as time goes, forward, you're meeting with someone, feel free to put a hand on hand, maybe hand on shoulder, something very subtle that doesn't obviously infringe on their physical, space. But be sensitive around physical contact in the sense that, as people feel accustomed or feel comfortable, they're going to they'll still show you that how comfortable they are. Obviously not something you want to necessarily do on the first meeting, but as you move into further subsequent meetings, maybe it's an opportunity to look at and examine. And now, obviously, making sure that you're comfortable and that individual is comfortable as well. In terms of environment, you want to make sure the environment is quiet. So, obviously, for communicating, it's important that you don't have too much in the background noise. If there's a radio playing or TV, you want to lower that, and then, of course, you can return it back to the original volume when you're leaving. And then obviously the whole point is to be kind to that individual. Do unto them as you would have them do unto you, right? That's the golden rule. Right. Okay, if you happen to be meeting with someone who is on the spectrum, perhaps they have autism or has autism spectrum disorder, you want to avoid any kind of use of subliminal humor or figures of speech or sarcasm. And the reason why this is the case is that they may not understand what you mean. And so you don't want to confuse them or upset them or frustrate them in any way. So use short, simple sentences and avoid any open questions. Otherwise, rather use closed-ended questions. For example, would you like to go outside? Yes or no? Would you like a drink? Would and move in that kind of regard so that people are able to correspond and understand what you mean. Now, in terms of your body language, this is an important point. Just be aware of how they feel. A lot of people, when you approach someone, if they're uncomfortable or maybe distraught, the natural reaction is to actually help them or maybe put your hand beside them or kind of guide them. I had a friend once, she had a sibling with a child with autism, and the child was getting into a bit of um, you know, uh, an upset kind of episode. And so what ended up happening is my friend reached out to him and wanted to, obviously give him a hug. And the parent said, no, actually, please refrain from touching him because with that, it complicates the matter more. And so, they say just to be aware of body language and how you respond physically as well. Okay. In terms of words, I use words like may instead of not. So things that are keeping obviously the opportunity open. So for example, we may go outside today instead of we're not going outside. So just to keep that flexibility in terms of understanding of what you're going to do and what your plans are. In terms of meeting with someone with a chronic medical condition, please remain calm. Often you may not even know a person has a medical condition and you won't need to communicate any differently. If a person is showing signs of distress or being unwell, please remain calm, use an unhurried tone. If Ask the person if you can do anything to help them. And of course, help them access support if there's anything they need. You can get assistance from the person, if it's at a nursing station or desk, or administrator, or a person in the home, if it happens to be someone living with the person. Okay. And ask them, obviously, and make sure you tell them what you're doing. Okay. If you're speaking to someone with a hearing difficulty, you want to let them know if you're having any trouble understanding them. If they happen to have an interpreter, maintain eye contact with the person who is deaf and often, use rephrasing of sentences as the person, may not necessarily understand on the first take. So rephrase sentences, try to change words so that you can actually, hopefully they can better understand you. Okay. And always face the person while speaking to them. Don't sit in front of a light. So if there's a light source behind my head here, it would be quite distracting because my face would be in a shadow and you may not be able to read my lips or be able to see what I'm saying. So definitely don't sit in front of a light or a window, for example, but speak directly to them in a place that's well lit. They can see your face and expressions. Sometimes, often, obviously, people will read your lips. And so if they have a hearing difficulty, they may not hear you, but they will be reading your lips. So it's important to keep that in mind. and also speak clearly, right? So obviously you want to ensure that they can hear you properly and speak as clearly as possible. If you are speaking, for example, with someone who happens to have a learning disability, again, one point here I'll mention is as people get older, they may sometimes have an acquired learning disability due to a condition or worsening health circumstances. And so it's important to actually relay the same, way that you would actually speak to anyone. You're still going to use short, clear, direct sentences. You can rephrase information as you need to, and consider using visual aids. Sometimes it's helpful to put, either an iPad if you have one, or a phone, like where you have a visible screen. You can actually show a visual aid in terms of what you're referring to, or you can bring something along with you that you can show. That is an assistance. One you could also do is provide opportunities to answer questions, write things out perhaps, and see if that helps as well. Okay. And anytime you can actually provide opportunity for them to interact with you in any way is much better, right? Obviously. So that's why we keep these ideas in mind. iPads are great for things like that if you want to pull something up quickly and share something with someone. Now, if you are meeting with someone who may have a mental illness, often you may not even know they have a mental illness, and you won't need to communicate any differently. Again, if a person happens to be showing signs of agitation, anxiety, panic, perhaps fear or disorientation, or even being aggressive, definitely remain calm, remain calm, keep your voice unhurried, make time to allow them to speak, and obviously show empathy, right? Without necessarily agreeing with what is being said. But you can say things like, I understand you're feeling frustrated. I feel you are, upset with what has happened. Try to share with them back what has occurred and what you see has happened. And please use, short, clear sentences. You also want to understand that you can accept that the hallucinations and their delusions are real for that person with the disability, but don't pretend that they're real to you. There was a case in point where a lady would meet, I believe it was with her sister. And so sometimes one of them had schizophrenia. And so the other sister, when she was in a room with her, sometimes the one with schizophrenia would actually say, is there a woman in the corner, like another person in the room? And that woman, her sister, would say, no, that's a hallucination. So then she knew, okay, that was in her head. That wasn't actually reality. So again, use short, clear sentences, speak clearly, obviously, and access support. If you need to, obviously, help them get the support they need if they're going to have some kind of, episode or something might happen that you feel that they might be at risk. Obviously, tell them what you're doing and encourage them, right? Because you're there obviously for them. If you happen to be meeting with someone who has a mobility issue, people may have various needs related to their mobility. For example, a person with a respiratory or a heart condition may have trouble walking. You might not notice it, but as time moves on, they may prefer a slower pace. They may ask you to slow down a little bit, or they might gasp a little bit, or have breathing issues. So just keep that in mind. Obviously, we all want to be at the same rate as a person as when you're actually meeting with, and you're having that opportunity to walk with them if you are going for a walk. But it's important to know that just to keep that in mind if in case they may have a mobility issue because of some underlying condition in their health. If a person uses a wheelchair, refer to the wheelchair in a positive manner, right? So say things like person who uses a wheelchair rather than confined to a wheelchair or wheelchair bound, right? The wheelchair is in fact something that enables the person to get around and participate in society. And it's in fact actually liberating. And so not confining. When you're speaking to a person who is using a wheelchair, grab your own chair and sit at their level. And if it's not possible, stand at a slight distance so that they're not straining their neck to look up and make eye contact with you. Okay. Be aware, of course, of the person's reach limits. So if something's not able to be they can't reach it by their hand. Be aware of that limit, and place as many items as you would like if they ask you to within their gas grasp. Excuse me. And please don't push or touch a person's wheelchair. It is what I call off limits in the sense that it is their mobility device. It is very personal and it's practical to them. And so they know it best. They know how to use it. My dad, before he passed, He had a walker, which he used, and that was, very well suited to him. And, it helped him with his mobility. And, oftentimes he would say, don't touch it. Don't touch it. Because he was avoiding anyone breaking it, right? Because if you break that, you're now infringing their ability to move around. And so then they have to work with it and they're stuck not being able to necessarily move as they would, right? With it. So it's important to keep that in mind also. So when you're talking to someone maybe with a speech difficulty, this is we want to make sure that you don't assume that they can't understand your speech, right? So they might have a difficulty speaking, but they may understand you perfectly. So that's the other point here. Always be patient, right? Obviously golden rule applies. Don't interrupt or finish the person's sentences. I have a bit of a habit doing that, unfortunately, and sometimes I'll be politely corrected when someone says, don't speak for me, which is good, right? We shouldn't do that. And so please ask questions that only require short answers. And what's valuable here is, you want to be able to understand one another. And so being attentive, don't pretend to understand. It's a difference if, you understand and versus you don't understand, and you don't want to kind of cloud over that opportunity. If you don't understand, please ask to maybe wait, ask if they could write it for you or bring a pad of paper and pen. They could actually write it down and show you written what they're talking or what they're referring to, and ask them to repeat themselves, right? If you can't or you don't understand, don't pretend, and give them your full attention, right? That's very important. Also, if after trying you still can't understand, ask them to maybe write it down, draw a picture, or suggest another way of facilitating communication, right? It's just simply being open to different ways. I bring up the phone or the iPad because it's a useful device, especially in these kind of moments where you can refer to something that otherwise you wouldn't maybe have used. Alex, sometimes when he talks about this particular topic, he'll mention that he has a cousin who is deaf, and that individual will often write everything down, right? And so it's very beneficial and easy to then, understand what they mean if they're not able to speak. All right. And so finally, we're going to just conclude this one segment about speaking with people with visual difficulties. Now, if you are meeting with someone you may not know they have a visual difficulty, you want to, first off the bat, identify yourself before you make physical contact with the person. So I always have, often will knock on the door, and if I'm coming into new space, I'll say, "Hi, my name is Kathy. I'm here from Compassion Community Care, visiting with Stephanie." And so they know who you are because they may not see you, right? They may not be able to see you depending on their visual difficulty. And so if you notice they have a guide dog, please walk on the side opposite of the dog and don't touch the dog. The dog is there to do a function and it's working. So you don't want to distract the dog from anything, any danger, or anything that they might be involved with helping that person. So we often say, don't touch the dog. Again, it's working and it needs to concentrate on what it's doing. As you are walking, perhaps maybe if you go for a walk or if you're walking along the facility area or grounds, describe what you're doing or what's happening around. If a person happens to notice outside there's something beautiful, often I'll bring that up and say, "Oh, look at this beautiful sunset." Or if it happens to be, part of the facility, it's a nice painting or something you notice that's beautiful, you can always bring that up. Obviously, describing the setting is helpful. For example, if there's any obstacles, let's say there's a crack or stairs, crack on the pavement if you're outside, or stairs approaching, you want to maybe mention that, telling them to go up or down, however needed. And, just ensure that they're safe, right? You want to make sure that they're always safe. And if you're giving them directions, for example, give specific excuse me, visual information. So listen for detail. For example, one thing some people have done is if they're looking at a plate, you could say, there's a garnish at 12 o'clock. And that gives them an orientation of where something is that's not necessarily edible, right? In terms of something in terms of visual that you could actually assist with, this is a large benefit, especially if you're meeting with someone, is to offer to read written information. Sometimes seniors will have a letter from the government or somewhere, some place that they can't seem to get to read, and they're maybe intimidated because they can't see it. So you can actually offer to read that for them. Okay, obviously everything is confidential, and so you're sharing that information to them, and it's a good opportunity to share that if they can. And if you are, for example, if you need to leave a person, if they're actually blind, inform that you're leaving. Ask them if they need anything before you leave. It's very practical, right? Like maybe you need to organize something or pick something up, or, and I always say this, put everything back exactly how you found it. Right? So if they have a business card or if they have some materials in a certain location, they ask you to take something out of a wallet, for example, make sure you put the cards back in the order that they were, because that is key. I know from my personal experience, I have a family member that's legally blind, and so they're meticulous about how they keep their order in their business cards, in their wallets, because everything has a space and a place, and it needs to be put back there. In terms of printing, if you have to print something for them, or if they ask you to print something, ideally you want to print it in as large font as possible, large print. Ideally, you would want it for a person, if someone has low vision, they may need written material in large print, but it's easiest for most people to actually, with low vision, to read bold white letters on a black background. But obviously, our world is not printed, white on black, but it's actually black on white. So if you can, if you please use bold letters in, largest possible font. And of course, as people age, your vision changes. I notice my own vision changes. I get older. My parents, I notice, are already starting to see less. They can't see the lights on necessarily on the highways, or sorry, on the streets. So you have to be aware of that, right? People need to keep on top of that. And so it's important for people to understand, if they have that difficulty, to share some of what you can do to help make them obviously deal with that, and help them in their day. So, all right. In terms of our next segment, we're going to segue now into advocacy at the doctor's office. Thank you, Alex.
Yeah, so actually, I was going to go back to this last section for 1 second because I do have an interesting story that's just recently affected us. So, first of all, I want to say something. When we were creating this whole section, you don't have to go back, it's fine. When we were creating this whole section on disabilities, the primary reason was is that as people get older, they might have had a stroke or they might just have lost, they're losing their eyesight or they're losing their hearing. So often these people have acquired disabilities. So when you're visiting someone, you may say, "Am I going to be visiting all these people with disabilities?" Well, in fact, you may end up visiting several people with disabilities, not because they always had a disability, but because over time they acquired a disability. But as for autism, I have a son who's autistic, Peter, and this is interesting because it's a good segue into advocacy at the doctor's office. So the doctor we have um, recently, I guess, had a breakdown or something. Anyway, we're at a medical clinic, is where we have our medical files at a medical clinic. And the one doctor retired at the medical clinic, so we had a new doctor. And I think that doctor had a breakdown because we got a letter saying, well, you're still with the medical clinic, but there is no doctor at the medical clinic. So this was interesting. So our son Pete's autistic, and so we found a new doctor in the area, and we signed up with that doctor, and he took us. So here's the situation. Pete being autistic, my wife went with him to the doctor's appointment. So let me put this into perspective for you. Peter is completely capable of communicating. There's no problem with communicating. He is autistic, so there's certain things that he likes to focus on, certain things he likes to do, and certain things he will never do. And that's just sort of how he is. It would be a little bit easier if he weren't, but this is how he is, and that's how Peter is. That's how it is. But when Susan went to the doctor's office with Peter, the doctor ignored Peter completely, even though Peter's an adult. Peter's around 30. He ignored Peter completely. He spoke to Susan, and Susan was really put off by it. No, no, you're supposed to be speaking to Peter. I'm just here to support Peter. I'm not here for you to speak to me. You're supposed to talk to Peter. And he wouldn't speak to Peter. So then she was so upset by it. The next week she sent me with Peter. So then the doctor was surprised we had another appointment. But she was just Susan was just really upset by this because first of all, he didn't properly assess what Pete needed, but secondly, and he was sort of dug into his ways. But secondly, he didn't speak to Peter at all. So then I come with Pete, and I just don't think he was realizing you really have to treat people in a way of equality. And this is where the whole concept comes from: how we speak to people, how you don't just touch their chair because it's their chair and it's part of what they use. We always ask them. You don't just come in and sit on their bed. You say they might say you can sit on their bed. That's totally different. You don't just do these things, right? You just don't do these things. And if someone's losing their hearing, it could be because they're getting older. Certainly, I didn't need glasses not that long ago, and now I can't read without them. literally can't read. So now we're going to go into advocacy. Now, we do have a patient advocacy training session that's going to be next week. That's going to be a wider patient advocacy. So this is just a small chapter which gives you the basics of advocacy. The reason we put this in right after is because when you're visiting someone, so let's say you're visiting somebody who you've known many years and they're a member of your church as an example, and you've known them for many years or known of them for many years, and you visit them and you realize, you know, this person is not receiving the care they need. And you think it through and you realize this person's got several health problems, and you realize maybe this person could use an advocate. And advocacy varies. You can see this when I'm going through the material with you, how it varies greatly. But you're thinking this person probably needs help getting the services that they need. So, for instance, let's say this person really should have some level of home care, and you notice that really they can't properly care for themselves anymore, things like that. And you realize, well, the doctor is actually the gatekeeper. So if I go in as an advocate, like I would maybe with my mother, or let's say my father, or maybe a sibling or a good friend, a family member, friend, etc., I would maybe do that for them also. But in this case, I might be visiting someone, and you assess that maybe this person really needs an advocate. And if you know this person well enough, they might agree, yes, please advocate for me. So advocacy is not an easy thing. There's nothing easy about it because you have to have a certain way of being to be an effective advocate. But we'll go through this with you. Sometimes people have trouble stating their feelings about their physical pain, their health issues, and an advocate can help them with that. Sometimes people are afraid to speak out. They have a lack of understanding. Maybe they're getting, let's say they're getting some early dementia, and so they're having a hard time fully understanding when they're at the doctor's office or when they're dealing with a medical care person. Sometimes they're just too ill to speak up. So what you might find when you're visiting someone that this person is just they don't seem to be getting what they need. They have multiple health issues, and when they went to the doctor, all the doctor did is prescribe them painkillers, And really what they needed is they might have needed something else. And as I say, they might have needed some supports from the community. And as you know, the doctor is often the gatekeeper to that. This a support person who can help the person. Well, you need to stand up for their rights sometimes. Of course, this varies, but someone might not be capable of standing up for themselves. Now, that takes a certain type of personality to effectively stand up for the rights. Obtain and maintain opportunities. Now, what I mean by that's the same thing when I said the doctor is the gatekeeper. So let's say, as I say, this person really they haven't been bathing themselves anymore. Maybe they're not capable of doing it and they need help. So they need a couple of hours a week of home care services and to someone to say to the doctor, well, really, Mrs. So and so or Mr. So and so could really use a couple of hours a week of home care service. They're in this state and their health is being affected by this. Gain access to support services. Sometimes people can't speak up for themselves. Talk with their healthcare providers. Actually, sometimes they don't want you to talk to their healthcare providers. They just want you to be there as a support person with them. But sometimes you need to talk with their healthcare provider. But you must be confidential because remember, when you're an advocate, everything you're involved in with that person, if you do advocacy, is that person's business. It's not your business. So you have to keep everything confidential. You have to be a very confidential person. How to be a good advocate. Well, let me tell you, we've gotten lots of phone calls. I know Kathy gets quite a few phone calls, but years ago when I was answering the CCC phone line, lots of phone calls from people. And sometimes you get a phone call from a family member and they're really advocating quite aggressively for mom or dad or somebody. And when you start talking to them, you realize maybe you're not the best communicator. And I don't want to be mean because some people have really great intentions, really wonderful intentions, but sometimes they're so aggressive with the medical caregivers that even if they're correct, they're so aggressive and almost disrespectful that they are almost causing a trouble themselves. And I know Kathy might have seen that too. I've certainly seen that in several conversations where I'm responding like, well, I don't think I would have spoken to the doctor that way, even though maybe you're right. You know what I'm saying? So you need to be a good communicator. And so what that means, well, you need to ask questions and you need to be a good listener. You must be courteous and respectful. So when I say this, I would always say to people, the problem with the situation is your doctor, your nurse practitioner, etc. they do have a fair amount of power if you think about it. You need them to provide care for you, but you also need them to advocate for you, as I say, if you need certain services. So you need to be very, very, very kind to them. Even if you disagree with them, you have to express it in a very courteous and respectful manner because you don't want to become the person who's actually creating the blockage of care where they get so upset at you they block you. But you need to at the same time be assertive. So it sounds difficult here. You need to be a good listener. You need to ask questions. You need to be a good communicator. You need to be assertive, but not so assertive that you're causing trouble. And you need to always be courteous and respectful. Okay, so in order to do this, to be an advocate for somebody, we first have to, well, arrange consent. But in that, you discuss with someone expectations. Now, I think this is very important about discussing expectations with someone. So let's say it's someone you've known for years. Often, just so you know, often when somebody wants to become an advocate for somebody, usually it's a family member they're talking about. They're advocating already for their mother or their father or a very close friend because they know their mother or father or close friend could really use somebody with them to help get the care that they need. Um, but sometimes you and that person don't share the same values, right? You don't have the same goals or ideas. So you need to discuss this ahead of time. You need to be willing and comfortable with advocacy with this person. Okay? You can't be an advocate for anybody, for everybody. Some people you will disagree with, and you don't need to find out you disagree with them at the time you're actually visiting the doctor. You need to figure that out ahead of time. If this is someone we share values with, I can be an excellent advocate. I'm willing to do what is necessary to help this person out, and I'm going to do it in a very professional manner. You need written permission. So we do have the advocate agreement in the booklet. It's the agreement is on page 95. So if you have it online, you can open it to page 95. If you have a hard copy of it, it's on page 95 of the booklet. So, and it's just a proposed agreement. You might want to change it a little bit, but it's pretty simple and straightforward, okay? Because you can't be an advocate and go to the doctor's office with somebody, unless, of course, it's your mother or somebody. So obviously, then it becomes quite obvious unless the doctor or nurse know that you are actually the advocate for them and you have an agreement with them and it's in place. Okay, and we move on. Now, what is the difference between an advocate and a healthcare proxy? This is sort of important because people get confused about this. So when you're advocating for somebody, you're advocating for somebody who's competent or usually fairly competent. So what's happening is you're talking with that person, you're supporting that person, you're acting on behalf of that person on their instructions, but you have no legal rights outside of that. You're not actually making decisions for them. Now, the Euthanasia Prevention Coalition, we sell something called the Life Protecting Power of Attorney for Personal Care. So, uh, Kathy could put it in the chat and you can then order it if you want. It's only $10. It's a very cheap way to protect yourself. We actually have several documents for different locations. I don't know if our document would be good in Mexico. I don't know. We have several documents for Canada. We have 3 different documents that are good for the US. Just so you know, most provinces in Canada use a similar format. Saskatchewan has the same format, but a little bit different language. British Columbia is a totally different format. Now, let me get back to it. The life protecting power of attorney for personal care is a healthcare proxy. So, what it does is that when somebody is unable to make decisions for themselves, meaning they become incompetent to make decisions for themselves, then that's when that healthcare proxy would kick in. So let's say your mother has appointed you to be their power of attorney for personal care. Now that's the Ontario language, power of attorney for personal care. So the person who's with us from other provinces, they might use a different language in that province, and that's fine. But the idea is it's a healthcare proxy. Your mother, let's say, appointed you to be your power of attorney, your healthcare proxy. If your mother becomes incompetent, let's say your mother had a stroke and she's unable to properly make decisions for herself anymore, then that document comes into place that you then would have to make medical decisions for them. So what's the difference? A healthcare proxy is comes into importance when the person you're representing has become incompetent and can't make decisions for themselves. So you're helping them make decisions by deciding as they would want. The advocate is working with someone who is competent and just helping them have the care that they need. Okay. Advocates, as I say, have no legal power outside of the fact that the person agrees that you be there. We move on. So, what do we do before a visit? Well, there's lots of things here. You need to know the time of day of a visit. Now, if you're going to go visit a doctor, the doctor might be late. I don't know. I know it's probably never happened before that the doctor, you know, was behind schedule. May never have happened before. Some doctors actually deliver babies. Some family physicians deliver babies. So you come in on your Tuesday appointment and you find out that the doctor is out because you might not know who's having the baby, but someone's having a baby. And therefore, all those scheduled appointments for that Tuesday, out of luck. You show up and then you have to go home because it's going to have to be rescheduled. These are just things that happen. Sometimes you have an 11 a.m. appointment and somebody else was maybe taking up that doctor's time and you end up seeing the doctor at noon or something and you're getting hungry. But anyway, you need to expect that the time of day. You have to expect it maybe to be late a bit. You need to gather information. You should gather information ahead of time. So you should, I'm going to get into this in a second. You would then meet with the person you're advocating for ahead of time. You find out if there's certain issues or concerns that the person has, and you have that knowledge ahead of time. You bring a list of the medications. So if the person is receiving X amount of medications, and I know Kathy used to talk about the fact before her father had passed that he had a whole series of medications that he was taking, and this is the kind of thing. Now, a lot of elderly people are actually, and I'm not talking about someone specific now, I'm talking about general, okay, general situations. A lot of elderly people are actually over medicated. I'll give you and this is not an elderly person. The other thing we were upset about with the visit that we had with the doctor is he prescribed all these medications for Pete. I don't, like Susan was like, what's he doing? Like, what's up with this guy? Honestly, we'd never met him before, and he's prescribing all these medications. We're thinking, I don't get this. So he was now taking, he not only didn't talk to our son, he just decided, oh, well, we're going to prescribe this, and this. And we're thinking, we couldn't get it. In the end, I'm not going to get into it. Anyway, bring a list of medications. Why? Because sometimes things contraindicate. Inform the doctor's office of your role. So if you have a signed agreement, you share that with them, and be prepared for a delay. It's very important. Bring maybe a bottle of water with you, a magazine, a good book. It could be a delay going on. So what do we need to accomplish? Well, we need to know ahead of time what are the person's concerns. So, sometimes you can't, as I say, I mentioned earlier, you need to have these discussions ahead of time with people. So maybe you meet them, let's say they have a doctor's appointment on Tuesday afternoon. Maybe you come on the Friday, so it's the week before, and have some tea and talk with that person. Just sit down and we talk about what's going on in their life, etc. And if they're visiting the doctor over a certain issue, you might ask a few questions. Are you having any other issues and things like that? And the person might say, yes, I'm having a real problem with my back. I haven't had that before. And so it's important to sort of know what is that person's concern. You might not actually say anything at the doctor's appointment. The person, as I say, might not want you to say anything. They might want to say your presence is enough, but you should know these things ahead of time because that helps that person, right? What are the person's medications, side effects, expected outcomes? These are important questions to discuss with the doctor, so you need to know that ahead of time. Do they have new symptoms? As I mentioned about the back issue, they might have a back issue. They might have something going on where they have shoulder pain, or they might have something going on where they always have a sore stomach or whatever it is. I don't know what it is. The point of it is that you should know that ahead of time. Do they want to talk to the doctor about sensitive issues? How do they want to talk to the doctor about sensitive issues? It's possible the person says to you, if I have to talk to the doctor about A, B, and C, please leave the room ahead of time. Well, it's good to know that, right? Everyone has the right to their privacy. As I say, your presence might be support enough. In fact, I can't emphasize that enough. the difference it makes to have somebody with you. When you're going to a doctor, so let's say you have a couple multiple issues of health, and they might not be overly serious individually, but of course combined, it's really, you'll have some concerns. But if you show up to a doctor, and let's say someone's a little bit older, etc., the doctor doesn't see you too often, etc., or the nurse practitioner, because often it's the nurse practitioner today, they're thinking, that person is thinking, but what do I do with this person? They're thinking, oh, that person's 81 years old. They have multiple health issues. They're thinking, what am I going to do about this person? So that's why you hear these older people going to the doctor, and what do they get? They get prescribed pain meds or whatever. And you're thinking, how could that be? They actually needed X, Y. They should have had a test. They should have found out what was going on. Um, but the doctor is not necessarily mean or cruel, and they're not a bad doctor necessarily. They're just looking at it thinking, I don't know what to do. They're obviously getting older. But when you have family members or a friend with you, you're seen very differently because you're part of a family. This is a friend. You have community. You're important. Okay, keep notes. So when you're visiting the doctor, but even ahead of time, when you're visiting with the person you're advocating for, keep notes, a notebook, a journal. Now, let's be very clear here. This is confidential. The note taking is not for your purposes. It's not so you can have information about somebody. And I'm not saying you would do that. I'm just saying it's completely confidential. The only reason you're taking notes and having a journal is so that you can help prompt the situation. So let's say so and so is visiting the physician, and the doctor says, oh, I think there's a concern developing around A, B, and C. And you ask a few questions about A, B, and C, and then you take a couple of notes. It's possible that the person you're going with has got some memory issues as they're getting older, and you're able to prompt them and say, well, remember, Dr. So and so told you that they have some concerns about this. People love to call me. Anyway, it's completely confidential. All right. You don't actually own that notebook. You might be taking the notes, you don't own it. It's the other person's information. Keep a folder of written responses also. So let's say there is an issue of certain health issues, and you ask the doctor to provide some sheets or some information about that health concern. Keep a folder of the written responses. My wife used to be a librarian. She sort of, I guess, is, but she doesn't do that anymore. And she worked for a health clinic. And so what was very interesting about that is, what would a librarian at a health clinic do? Like, how many books are at a health clinic? Primarily what she was doing is the doctor or the nurse practitioner would say to her, oh, can you find out certain information for me? And then she would go into the database, and then she'd pull up sheets of information, and she would then give it to them, and there they would have it. That's what she was doing more than anything else. So it's interesting, as I say, about the whole thing about information folders and all that information. The other thing is, Dr. Google does provide information, but sometimes it's better to get the official information from the doctor. We move on. During the visit, take notes. As I say, those notes are completely confidential, respect the person's privacy. Ask questions, unless they tell you they don't want you asking questions and they just want you there as a support. Ask questions, but always be completely polite. So let's say the doctor was talking about a concern about this medical condition that seems to be developing, or this situation. Just politely ask a couple questions. You don't have to be difficult about it. You can ask straight questions, and don't be intimidated just because they wear a white jacket or they've got a plaque on the wall saying that they graduated from this university and they're doctor of this type of medicine. That's great. That's wonderful. Be polite, but don't be intimidated by them. They're just people. That's what they are, and we treat them we treat them respectfully as another person. Suggest they provide answers. So let's say it's a situation and they're just talking about it. Well, can you tell me more about it? Can you tell me more about it? Maybe it's the nurse practitioner then is going to who will be in the room and providing those answers, and that's fine. Inquire about services. Now, I've mentioned this a couple times. We know it's true. It's very hard now to get services. I'm not saying that it's impossible, but it's becoming harder and harder in our medical system to get services for somebody. And it shouldn't be that way. It seems to me that there's becoming more and more of a tightening of home care services. So unless you're, and I have to be very careful what I'm saying. My daughter-in-law is a nurse, and she works for one of those home care nurse companies. So she goes to people's homes and that, and she's kept reasonably busy. But most of the people she's actually visiting are people who've just had a surgery, or let's say they're approaching death. And because they're approaching death, they need some sort of level of palliative care. So she's taking all that palliative care training, etc. Or they're in some specific situation. I'm talking about these people who are providing, let's say, basic home care services, etc., that you would get from the, from the LIN that would get approved for, let's say, 2 hours of care a week and that kind of thing. It's very hard to get these services today. But inquire about the services. You have to sometimes make the case that, oh, I was visiting Joan. Jones is the name I'm using, obviously. And she really could use some help. It's really actually getting a situation where I think it's affecting her health. And you almost have to say that. Ask for information sheets. As I already said, that's what I brought up before. My wife, when she was a librarian at the medical clinic, that's really a lot of what she did, providing information sheets. They have them. It's not a problem. We move on. Make follow-up appointments. Now, often you're working with somebody who has some memory issues. Let's say they're older. And so they may not want you to make follow-up appointments, but if the doctor said, I want to see you in 3 months, they might be happy to make the follow-up appointment. But if they're having some memory issues, just say, well, Dr. So-and-so said they want to see you in 3 months. I'll help you make that appointment because you're right there. You do it with them. You have your calendar with you. You help them make an appointment because you're their advocate. Fill any prescriptions with them. So go with them to the pharmacy, help them fill their prescriptions. I also tell people you have this list of medications that we've told you. Always bring the list of medications with you when you visit the doctor with someone. When you talk to the pharmacist, it's sometimes good to have that list of medications also. Now, why am I saying this? First of all, pharmacists today, they want to be consulted because they're being told that that's something that they can do, and they can then how would you say they charge a little fee for that to OHIP in Ontario for being consulted. But secondly, pharmacists actually know a lot about medications. So if there is something contraindicating and maybe the doctor didn't notice that, the pharmacist probably would notice it. Okay. I discussed the appointment with the person. So after you've had that medical appointment and you sit down with the person with some tea, go to their house where it's nice and private and talk about it. And there's a good reason to discuss the appointment. It's possible the person wasn't comfortable with the things you said, or maybe felt you were too aggressive, or maybe thought you spoke too much. It's important to discuss it with the person and have those discussions with them. As an advocate, you're valuable, helping to make our world a better place for those in need. Now, uh, Advocates Code of Conduct. Now, you'll notice in the booklet, when you go to the booklet, it actually has a whole little section again about that was specific to note taking. And I want to emphasize that one more time about note taking. It's completely private. Now, this code of conduct will make you understand why you can't be an advocate for just anybody. It says, I will practice with compassion and respect for the person with whom I work. My primary commitments are to promote the health, safety, and rights of the person. Remember, an advocate is helping somebody. You're not making decisions for somebody. I will be transparent in my work with the person. I'll maintain privacy on behalf of the person and keep confidential all activities and records. Now, this isn't unless speaking with my supervisor for advice. So if you're working for an agency, or let's say it's within, let's say, a parish model of care that's being provided, you might want to speak to someone who you're working with if there's a big issue. We move on. I will guide and assist the person in medical decision making, but at no time will I make decisions about health or medical care or medical services on their behalf. I have no right to make decisions for them, but I can help them make decisions and communicate with them. I will respect the person's values and belief system as the foundation for decision making. Now, this is very clear. If that person doesn't share your values, you might be in a situation where you start becoming uncomfortable with what that person's asking you to advocate for. You can't be an advocate for them. The life protecting power for personal care is a personal care document. It's legal. We have different types of documents based on what province you're in. It's very cheap. It's about $10. It's the cheapest way to protect your life. It also talks about euthanasia and assisted suicide in it. You can order it through me at info@epcc.ca. info@epcc.ca, or I think Kathy put a link in in the tab thing already. So choose the power of attorney for personal care as based on your own values. Okay, based on your own values. I'm going to say something else about power of attorneys for personal care just because I have a bit of time, and I'm not going to take up all your time. I know you probably think, oh, those guys going to speak on. No, it's important when you have a power of attorney for personal care and that the document is written in such a way that protects you, that shares your values. But also, it's so important that you appoint someone who represents you who shares your values. And I'm very clear to people, don't appoint your oldest daughter to be your power of attorney for personal care or to make decisions for you when you can't make decisions for yourself if your oldest daughter doesn't share your values, because you're giving them power over medical decisions, right? You're giving them the right to make medical decisions for you when you can't make decisions for yourself. So I always say to people, I'm not going to tell you what to do about your will or your power of attorney for finances. It's possible that your oldest child in your family that you had is going to be excellent with making financial decisions, or excellent in representing you after you've passed away with your will, etc. But with your health care, you have to only assign somebody who shares your values. Believe me, you've given them a lot of power. I got a call from this woman. Well, I've gotten calls of lots of people, but I mean, this one case just absolutely floored me because the woman calls me and her sister was the person who had the power of attorney. And her mother had had a stroke. It was not a major stroke. So she is now every day sitting with her mother, but the one her mother appointed is not there. But then the one she appointed, because her mother was considered incompetent, decided to stop giving her mother food and fluids. So the hospital then had to agree, no more food and fluids. And they only gave her then morphine, etc., to keep her from being in pain and suffering and to put her in a type of sleep state so she can die of dehydration. And this woman calls me up, and I'm absolutely broken by this because this was several days into the process already. And I'm absolutely broken by this because this woman is absolutely suffering watching this happen to her mom. And her mother, sadly, should never have appointed her. And the problem is now how can you remove that when the mother is incompetent? You can only go to court then, and it's not easy. It's not easy. It costs a ton of money. You probably be unsuccessful because your mother appointed someone while she was competent. So obviously she made that decision. So now you're trying to prove that the other family member who was appointed is making decisions that are not in the best interest of your mother. It's horrific, okay? It really is horrific. So please do me a favor. Only appoint someone who shares your values. Move on. Okay, advocacy training. So that's going to be a much longer session from 7 to 9. Actually, it usually doesn't take 2 hours, but we have lots of time for questions. But nonetheless, we go through significant issues around advocacy. There's a lot more to it than what we just went through. This is the basic overture, but to become an effective advocate, I think you need to look at this in a wider way. Also, the other thing is similar to compassionate, the visiting. Often people start experiencing, disabilities, etc., as they get older, and it's important for the advocate to understand how to communicate and how to help them and how to work with the person they're working with. Once again, uh, you really can only be an advocate for someone who shares your values. So you can register for November 6th. You'll be stuck with Kathy and I, but we'll do a really good job. You'll be happy with it. We'll move on. Elder abuse. Now, I don't like talking about elder abuse. This actually always upsets me, and it should upset me. But the fact of it is that I'm not suggesting if you're visiting people, let's say you're visiting people in your parish or your community, etc., I'm not suggesting you're going to bump into a case of elder abuse. All I'm saying is if you do, you have to be able to identify it and you can't remain silent. You just can't. You have to be willing to react to this issue. We're going to go through issues around elder abuse. Some of it is quite difficult. So what are the signs of abuse? Well, obviously there's lots of signs of abuse. The difficulty with abuse is you might be, let's say you visit someone and you notice that there's certain issues, um, and then they give you certain reasons that don't make sense, like they're giving an implausible reason for the injury. Well, the problem is if you don't really know the person, the first time you see them, it's going to be awfully hard because you're looking at something that seems unacceptable, but they might have fallen. You're right, they might have fallen. They might have burned themselves. They might have accidentally cut themselves. Everything they're saying might be true. The problem is if you go there and you're visiting them every week or every second week, and you notice that this is a consistent problem, then you know you've got a real problem. And you can never remain silent if the signs are too clear. You're better to um, do something uncomfortable by sort of bringing it up than to let it continue. The other problem with elder abuse, obviously, is that often elder abuse happens by someone who's close to them. And so, therefore, they often will make an excuse. Very often elder abuse is done by a family member or a close friend. And if it's a family member, then what happens is that the person is sort of blaming themselves. So, what do we see? We see sores or injuries. They have vague or implausible reasons for the injury. Um, Prime example of that, they have an injury. So let's say they hurt themselves. It looks like they were hurt quite seriously or somewhat seriously, but they never called the doctor. Why didn't they call the doctor? Well, when it's abuse and they're trying to cover up for the abuse, they don't call the doctor. They're not seeking care for their injury. So messy, unclean appearance. Now, this is primarily an issue if you've known this person was not a messy person and definitely not an unclean person, and then you go visit them and they're messy and unclean and they have this appearance, and you can tell there's something going on. Malnutrition and weight loss, especially when we're talking about someone who, let's say, has a family member who's doing financial fraud to them. That often results in them having no money. Like when you go visit someone, you're talking to them, and literally they have got nothing. This has happened to me actually. They literally have nothing, and yet you know they've had a successful life. And you scratch your head thinking, what is this? And you start realizing, oh, it's the son who comes visit and takes all the money. And guess what? There is no money. There is no money because the dad is giving the money to his son because he loves his son, but he's not thinking how crazy this is because he's got nothing. And he's had a very successful life. You know what I'm getting to? I had this situation. Dehydration is a big issue. Now that can happen in the hospital also. Someone's afraid of you. You're talking to them and they sort of react. And you're thinking, well, why are you reacting? I've not done anything. Clearly, I'm not coming into your space. I'm respecting your space. And you're reacting funny. There seems to be a sign here. Financial fraud is massive. You'd be shocked, and I guess you're probably not shocked because you're hearing about it in the media, how often this happens. Exploitation. And of course, sexual abuse does also happen. And that's obviously very difficult to deal with. Once again, I'm not telling you you're going to bump into abuse. I'm just saying if you do, and it becomes quite clear to you, you can't remain silent about it. And this is the whole reality that we have to talk about it for. Okay. Physical abuse is an act of violence, may result in pain, injury, impairment, or disease. And neglect is a type of abuse, but it's the failure to provide goods or services necessary for functioning or to avoid harm. So let me say this: what's different. So a physical abuse is someone's actually hurt you, whereas neglect means they've denied you. Usually, that I'm not sure if that's a perfect definition, but you can sort of understand someone's been denied proper nutrition, etc. In the case of neglect, in the case of being hurt, someone's actually hurt them per se. Doctor or healthcare providers not notified. That's a big, big sign. Wound is smelly or dirty, meaning you can see that there seems to be signs of infection. It's not been cleaned. No one's properly taken care of this person, and yet they have, let's say, a cut or something, and it should have been dealt with. Nothing's being dealt with. Why not? Because the person is not they're covering it up is what's happening. And why are they covering it up? Because it's a family member, it's a friend, it's someone they know, and they may also feel guilty about it. They should not feel guilty about it, but that's not the situation. They feel guilty about it. They think it's somehow their fault. The person has not received any medical care for their condition. Big sign. Big sign. We move on. Most common injuries, well, bruises, pressure sores, fractures, they're a little different. Bruises of pressure, abrasions, they're Superficial injuries involving the outer layer of the skin. So you see a bruise is caused by the movement of the skin over a rough surface, like someone could be hurting them, they fell, etc., etc. Evident in both physical abuse and neglect. Okay. Now, what you'll notice that is if it's common. So you see someone, they have this type of a bruise. Let's say they have a bad, really bruise, let's say on their neck as an example, because that's a common sort of place. And then you come back 2 weeks later and they have it again. Or on their arm, someone's been grabbing them type thing. Happen when a blood vessel, say bruises happen when a blood vessel ruptures and blood escapes into the surrounding tissue. May be a cause from an injury. A common location, as it says, face, neck, etc. Those are common accidental injuries too. Now, let me make a comment about bruises. You know, when we're talking about the same idea about the blood vessel rupture, you notice that someone is actually, just so you know, just the information. Let's say someone's got an IV in and they're in the hospital, and you notice that there's a lot of bruising around it. That's a sign that they're getting too much fluid. Now, that doesn't necessarily mean that they can't use fluid, but it does mean that their, how would you say, their circulatory system, etc., is not effectively moving the fluid. Now, I'm telling you this because this is a very common sign that someone's approaching death, and we get these calls all the time, and it does fall into the thing of bruises, so I throw that in there. It's just one more piece of information for you. Burns result in the tissue exposed to heat above 50 degrees Celsius. Now, why are burns such a big issue? Now, obviously, a burn is pretty bad because as you get older, it's harder for it to heal, and it has more damage. But we say here, of course, burns are categorized by how much surface area is affected and how deep the damage is. First degree burn, second degree burn, etc. Anyway, what's important here is that a burn that might result in your death, and you might thinking that would be a very significant burn. It can be, or it might lead to not healing effectively and then getting infections, etc. But just so you know, persons over the age of 65 have double the average death expectancy due to a burn, but it becomes triple at 75. So I mean, I'm 57, so I'm not 65 yet, but I'm getting older. But the point of it is I'm 57. So let's say if you look at how a burn would affect me compared to someone at 65, 75, or 85, you understand at 85, it becomes incredibly serious to have a burn because the healing, the effect might result in a death, etc. We move on. Fractures occur when an external force is greater than the strength the bone is applied. So, you know where I'm getting to with a fracture. Maybe someone's been hit, etc., very hard or something like that. Older people are also more susceptible because they might have bone disease or an injury. But as you get older, your bone density becomes weaker. It's good to weight lift actually, just so you know. If you weight lift, you're strengthening your bone density. Even if you don't do massive weights, you're just doing it for a bit of health reasons. Weightlifting is very good for your body. You don't have to be super strong to do a little bit of weightlifting. Common sites are often the hip or the wrist. Well, you hear, of course, people breaking their hips and how it's a real problem when they get older because they fell or something or they got hurt. Wrists are bad. In fact, talking about this fractures, wrists. This happened by accident. My mother broke one wrist a few years ago, and after she got better, she broke the other wrist. And both times she fell. She wasn't living with anybody, so it wasn't anything like that. But you can see how these things happen, that your body becomes weaker. Elderly people are at risk of spontaneous fracture, absolutely. But it can also be an abuse that leads to that. Laceration is a result of a blunt force, characterized by full thickness splitting of the skin, common in physical abuse, but can occur with neglect. Lacerations are something that you'll often see. It could be a caregiver neglect that leads to it also, as I say. We move on. Pressure sores. Now, pressure sores are quite important, and it is a form of abuse not to properly care for someone. You might remember, you may not have seen it, but anyway, I wrote about it. The story of Norman Munier in Quebec. Norman is a man who, in 2024, is January of 2024, He was in Quebec. He's in Quebec. He passed away though of euthanasia. But anyway, he was in brought into the hospital because he was having some breathing issues. He was a man who had quadriplegia, so he's in a wheelchair, etc. His wife was caring for him, but he had some breathing issues. He actually ended up they diagnosed with pneumonia. They brought him into emergency, but there was no beds available for him. They had a lineup of people in emergency. They put him on a stretcher and they left him there for 95 hours. Sorry, that is abuse. Because if you're anybody who has um, you know, quadriplegia, or maybe you're disabled and you're in a wheelchair, you have to move around regularly because you can't have your body in one spot all the time or you develop pressure sores. Give you another example. I've been visiting Roger Foley regularly. Who's Roger Foley? He's a man who has cerebral ataxia, or he would say cerebellar ataxia type 14, I mean, and he lives at Victoria Hospital in London. He's received a lot of terrible care. Terrible care. It's horrific. It's ridiculous, actually. Sorry, it's insane. Um, Maybe he should move to Mexico, and I shouldn't joke about it. I know, but Kathy's smiling. She knows it's been bad, okay? But anyway, the point of it is that he has a special mattress. He's always moving around. Now, why is he doing this? Because he can't afford to get a pressure sore, because pressure sores can cause death. What is the best standard of care for a pressure sore? Prevention. Anyway, Norman Munier developed a pressure sore after being on the gurney type thing for 95 hours. It was a bad pressure sore. It ended up being so bad that he had massive infection, and then he ended up quote choosing to die by euthanasia. Well, the whole thing started out as abuse, okay? Now, if someone's in a nursing home and they're not being turned, let's say that someone has some dementia, they're in a bed, they shouldn't be in a bed all day anyway. That's not proper care, but they're in a bed. You have to turn them regularly. If you don't turn them regularly, you need a special mattress. But if you don't turn them regularly, they get a pressure sore, then guess what? It turns into an infection and goes on from there and often results in a horrific death. Okay. So this is just gives you some ideas. Stage one is skin is broken but and inflamed. And then skin is broken further. So you see that there's a deeper sort of sore that's developed with the pressure sore. Stage three is it's like an ulcer, and you see how deep it's gone, but it's still not down to the bone yet, at least. And this is stage four was what had Norman Munier had, and it was right down to his bone. Now let me give you more information, just so you know that this is very, very, very serious and is very important for people with disabilities. So I was just hanging out in Ottawa Monday, Tuesday with Gordon Friesen, who's the president of the Euthanasia Prevention Coalition, and Gordon has been he's had a wheelchair since he was in his early 20s. In his 20s, he had an accident. He meticulously avoids pressure sores. So you're going to find this a little bit funny, but it was very serious for him. He was with us we did a press conference, we did a bunch of things, and he was in his wheelchair for a long period of time. We were visiting a member of parliament. Now, this was a friendly member of parliament. It just wasn't somebody. It was a friendly member of parliament. We're visiting the friendly member of parliament, and Gordon asks, "Can I lay on your floor?" And he looks at me and he says, "I have to get out of my wheelchair. I don't want to be in a situation where I develop a pressure sore." That's exactly what he said to him. "So can I lay on your floor?" And he says, "Well, go ahead." So I helped get him out of the wheelchair with another person. We put him on and he says, "Oh, this is a perfect floor. It's totally relieved me of any pressure on my body that I might have had for." And you're thinking, isn't that silly? But it actually was very smart of him. And then we're talking to this member of parliament, and then we hear some voice coming from the floor. Of course, it's Gordon talking. But it was perfectly good, and now when you understand why he did that, it makes total sense. Because he didn't want to develop a pressure sore. He'd been in that chair for a couple of hours now, and he's afraid that if he gets a pressure sore, he's done for. And I can get more into that than that. I can tell you lots of stories of friends with disabilities. Restraints. Well, just so you know ahead of time, restraints, we understand in a sense restraints because someone could be quite aggressive. But there are countries that have made restraints illegal, just so you know. Canada has not made restraints illegal. Uh, as an organization, Compassionate Community Care discourages restraints to the utmost. We believe that you should not be using restraints. If you're visiting someone and they have significant dementia and they're restrained, that's not a good thing. It often leads to them being more aggressive. Okay, a person is restrained in a non-critical situation. I consider that abuse. We're telling you we believe that's neglect or abuse. It's not critical. You do not restrain people. And also, if they're not closely monitored by the medical professional, that's abusive. The restraints are too tight. That's abusive. Restraint is also strongly associated with increased injury or death, meaning people who have restraints, often it leads to a much earlier death or they have injuries from it, and it results in a much worsening of behaviors. In sites other than skin tears, in sites other than arms or legs, or multiple tears or abrasions should raise suspicion. Skin tears heal without scarring. Often, okay, malnutrition. Well, malnutrition is a serious issue, especially if someone's in hospital care, nursing home, etc., and they're not being fed properly. First of all, there's feeding techniques that are necessary. Now that Kathy and I know Roger Foley really well, and now Roger Foley, you have to feed him properly. He is capable of eating. He does swallow. But the fact of it is he has to have pureed food, and he has to be in a certain position, and he knows that if he's fed improperly, it could result in him having regurgitating into his lungs, and then of course that would lead to pneumonia, and it could be a death sentence for him. So he's very particular about that, and he wants to make sure he's being fed properly. And in fact, feeding's been one of his big issues. The whole abusive situation was not being fed properly. Just so you know, they say not enough staff. It's very interesting. A woman I know quite well, I think she's probably passed away now. She worked at a nursing home and she was like the cook. She'd make food and everything. And she used to say to me, it drove her crazy. This is a woman who's in well, she was in my community. And now then she moved to London. She might have passed away because I've lost track of her. She would be quite old now if she's still alive. But anyway, she worked in a nursing home as a cook. She was quite a good cook, etc. She knew she'd worked in past in restaurants and other things, so she knew what she was doing. And she would say, at the end of my finishing and all the food was ready and everything, she said, I wasn't the dishwasher, so I used to go out and feed some of the residents. I was done cooking. The food's all ready. The people are bringing it to them. I would go there and help feed certain residents. And then she says, then I was told by the union that I wasn't allowed to do that because that wasn't my job. She's telling me this. And she says she was so frustrated because some people, the food's in front of them, they need someone to help feed them. Of course, there's quite a few people who you may even know who go regularly to feed their mother. Their mother, say their mother's in a nursing home, and they go every night to feed their mother, or make sure someone's there every night to feed their mother because she needs someone who's there to talk to her, be nice to her, and help feed her because of her level of health. She's able to eat. She's willing to eat, but she needs someone to be there to make sure it's done. There's also say proper feeding techniques. You can't feed someone laying down. So you think of someone, let's say they're in a hospital bed and they're laying down, you can't do that. You can't do that because it gets into their lungs. A prime example, let's say someone has a G tube, so the food is being fed to them, so they have the type of that liquidized food that goes straight into their stomach. If you do it as they're laying down, then of course it comes up. Can't do that. They have to be set up properly. All these things are properly done, okay? Um, Cultural preferences is also an issue for food. So let's say if someone was only eating Chinese food all their life. This is part of their culture. They're an older person. They might have emigrated to Canada later in life, and now they end up in a nursing home and they're being told to eat food that maybe I'd be happy with. Um, no, that's probably not going to work very well. We move on. Dehydration is very serious. Signs and symptoms, confusion and sleepiness. So, you'll talk to someone and they'll say, oh, my mother's not doing well. She's become really, she's in a nursing home and she's become really confused and she's sleeping all the time. And, they're giving her extra medications because of this. They say her dementia is really, moving on quickly, etc. And, well, it could be dehydration. A prime example, when my wife was younger, She's not an old girl, but when she was younger, she was a teenager. She was working in the hospital as a, what did they call them years ago? Candy striper. So her job was to go visit people, talk to them, and help feed them. That's what she did. And there was this guy there who literally everyone thought he was on his deathbed and he was dying. But in fact, he had a medication question. That was the first thing. But secondly, they said, "Oh, well, he was because he was in this case of confusion and everything. He wasn't eating, he wasn't drinking, the whole bit. So they changed his medications around and they put fluids in him. He came back to normal. He went home. Serious. I'm not lying to you. So, obviously there was a medication issue on top of it, but often in this case, someone older, they might change the medications. So they're thinking, oh, well, they're confused all the time. They're sleeping. They're not thinking, oh, this person's experiencing dehydration. We move on. The other problem with an older person in the situation of medications is the body has less fluid in it when you get older. Your body changes as you get older. A younger person has a higher fluid level, but that also changes the absorption of medications. Now, doctors who are dealing with older patients obviously should be quite aware of this, so I don't think I'm telling anything new. But what I'm saying is that affects the effect of medications on them. We move. People with dementia. Well, a lot of people have dementia, even if it's an early stage and then it starts progressing. That may not be recognized, but let's say they're being abused also. The problem with people with the dementia being abused is that even if they report their abuse and they talk about it, they may not be believed. So this is a very serious issue. And if you know somebody and you know them reasonably well and they're telling you this, yes, they might have certain level of dementia, but why would they be talking about it if it's not true? It's possible it's not true. I understand this. I know there's nothing easy about any of this, but obviously speaking, it's a serious problem when somebody with dementia is being abused and they're not being believed. There's been a couple of cases where somebody has put a camera in the room where their mother or father might be, etc. And then they pick it up on the camera that yes, mom or dad was being abused. My mother-in-law, when she passed away several years ago, but when she was in the nursing home, she passed away around when she was around 90, but she was having problems with one of the staff, and she didn't tell anybody about it. So this goes back to the whole thing about abuse in that sense. She didn't tell anybody about it. She was talking to my wife, her daughter, that is, Susan. She was talking to her about it, saying, "Oh, well, this nurse has done this. She's taken my things. She comes in my room. She does this. She's doing that, and I tell her to stop it, and she won't listen. She lost some of her clothes. She says the nurse didn't return some of my clothes. Da 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 da. Okay, and it was going on, and but she wasn't willing to tell the staff because she was afraid that the neglect, the abuse would be worse because she had this nurse. Now, this might not have been a nurse. It might have been an orderly. Someone who just worked for the nursing home. Anyway, so my wife Susan, she called them up and said, so and so has been doing this to my mother, and this has to stop. And in fact, my mother-in-law never saw that woman again. I don't know if they fired her or not. I got no idea. All I know is my mother-in-law never saw her again. She wasn't on that floor anymore. She might have been fired. Self-neglect accompanies dementia and mental health problems. When someone is losing their memory, having issues, it often leads to them becoming depressed. It affects them emotionally. None of this should be a surprise to you. We're all human beings. Abuse and neglect often also leads to depression. So someone who is being abused and they're having issues, it affects their self-esteem. They often blame themselves in some way because it's usually someone they know who's doing this, and it often can lead to depression, them feeling down. We have to watch out for these things, and you see that someone has to be we need to protect people. We move on. Alcohol abuse. Well, I like a beer, but I more like a glass of wine, actually, to tell you the truth. But anyway, 5% of older persons have a problem with alcohol. Um, More common in men than women. I think that's actually changing a bit now because we're seeing a real change in the difference between men and women and how they consume things. Culturally, things have shifted. Lower levels to feel ill effects when you're older. So an older person obviously can get drunk quite easy and they're having problems. Now, financial abuse. Well, I've mentioned this already. You're going to hear a lot more about it because it continues to go, especially now with AI. So what I mean by AI, this intelligence, this computer intelligence sort of system because they're able to use AI. So let's say my voice is being caught now on this recording, and AI was to grab my voice and then use my voice to contact my mother to say I need money. Now my mom hopefully would call me first, but you can see how that can happen. So that's why they get phone calls from someone and it's like saying, "Oh, grandma, please, send me $10,000. I'm in such and such and I have this problem. I'll pay it back as soon as I can. I'm in this terrible situation." And grandma's actually thinking because she hears the voice, "Oh, it's her granddaughter. Of course I'm going to help my granddaughter." And guess what? She just got duped by technology, and these people are professionals. So when you hear about this going on and about the financial abuse that's going on and how bad it is, often people say, well, how come that person was so stupid? Well, you can't think that way because it has nothing to do with it. What it is that they have professionals who are taking advantage of people. Serious problem. So when you're just visiting someone, you're talking to them and they say, "Oh, well, my granddaughter called yesterday and da 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 da," and you're hearing this thing. Well, if it actually was her granddaughter asked for $10,000, your antenna should go up anyway. But if it wasn't, it might not have been her granddaughter. You know what I'm getting to? That's the example I'm using, obviously. But you know what I'm getting to? Financial abuse is incredibly common. It's very sad that this is going on. It's also caused another problem. People donate money to Euthanasia Prevention Coalition. And so when you call them up and just sort of remind them that they haven't renewed their membership, or we call it friendship, we're just being kind. Obviously, you don't exist without donations. uh, you have to be very careful because they're talking to you on the phone. So you're saying yes, yes, it's myself and da 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 da. Da. And obviously, I'm trying to be very careful because I don't want someone to think that, oh, this might be a scam, because that's the last thing I wanted them to think. We move on. Okay, so we have the training coming up, free in-person online Zoom training. We've done this here, but also we got the training coming up on the November 6th. It's wider. You're probably saying, how much more can we talk about certain things? Well, in the case of elder abuse and other problems, we will touch on that again, but that's not the primary thing we're going to touch on, of course, on November 6th. It's the whole thing about advocacy and how to properly do advocacy. There's future training. We did record other training sessions. So if you really liked what we had to say, but you wanted to see maybe what we said 6 months ago, Kathy has some of those recordings. She's happy to share it with you. It might be a good reminder. The booklets are available to you. These booklets were put together based on best practice. So what we did when we created this whole training module, it wasn't that we got together and thought, oh, what would be good? No, no, no. What we did is we looked at best practices, other people already putting out manuals on how to visit people, etc. For instance, the My Story, which you guys dealt with yesterday, the My Story came out of research. My wife was researching all these different things. Susan, she was doing a ton of research on this, and she found this university that sent people in and did significant research on the concept of the individual and how they feel about themselves, and how you rebuild one's self-esteem. And this research showed very clearly that when you're actually interested in somebody, now, because remember, the whole thing of My Story is really good. I'm just recapping something. I wasn't with you yesterday. I'm sure Kathy covered it incredibly well. But you know what I'm saying? Uh, when you're actually interested in somebody, I mean, them personally, it really makes a difference for how they feel about themselves. So when you're visiting somebody and you ask them these questions about them, it does two things. First of all, it gives you an in because you're asking them about them and there's a reason to visit. But secondly, you're actually really helping out their self-esteem. Anyway, I think I'm done now, and Kathy's going to do the closing off.
Thank you so much, Alex. That was excellent. So ultimately here, we are here to provide you some tools, some resources, and Alex mentioned the books are available. So if you'd like a hard copy, feel free to reach out to us by email. I can mail them to you, no problem. And it is an opportunity to empower you so you can empower others, right? And all of these trainings are available on our website, compassionatecommunitycare.org, or the shorter version is beingwith.org. Under the events tab, you can click on there to register for the patient advocacy. I did post it in the chat, so for anyone who's interested, please refer. I'm going to just do that again right now. And for everyone, you can click on that link here in the chat box. That will take you to the registration page, just like you registered for tonight, yesterday. You can register for the next week's session, which is on the 6th of November, which is a Thursday. And so we look forward to hosting you then as well. Alex will be speaking and myself, and we'll just be focusing on the patient advocacy side, okay? How to communicate and be an effective advocate. Now, for tonight, if any of you are interested, we do have a certificate. I can issue that for you if you need it for any purpose. Obviously, if some of you are starting visiting in a community or a cult, a faith community, for example, church, and you need something like this, you can present it. No problem. We can issue that for you because you're technically all graduates now. Again, that training is happening next Thursday, November 6th. Now, we did take, as I mentioned to you, a number of surveys of ladies who reside in the London diocese, and we happen to be in that area in that diocese. So they partnered with us just before COVID, during COVID, and interviewed a number of their members, the CWL, which is the Catholic Women's League group. And so we collected over 55 testimonies from these ladies who share wonderful accounts, testimonies of their lives, of their ministry work, how they helped in the community, how they were raised, how they raised their children, how they worked in the world, and what they ultimately did and felt that they accomplished most in their life. And so it's a beautiful account, collection, and really creates legacy. And we called it Her Story, which was a special edition we issued. We would be very interested in doing another one, and maybe of a collective of group of people, for example, in the community who are willing to submit their stories. So feel free to reach out to us if you end up interviewing someone with the My Story approach, and you can actually have them published as well. In that book, you'll find stunning testimonies of life, love, family, struggles, perseverance, and hope. The lady in the middle actually just passed away, sadly, earlier this year. But before she passed, she actually, in this picture, she's here pictured at 90 years of age, young, and she passed away, I believe. Well, she submitted her story when she was 94. I believe she lived till 98. So sorry, yeah, so 4 or 5, yeah, around there. So just within 3 years after the stories were submitted and published, she actually bought around 10 copies, which she gave out to her grandchildren, and now they have this living, lasting account of her life, which is beautiful because it can get, obviously passed on to the next generation and show what amazing woman, they had in their family. So there are gray accounts. Some of the ladies have passed, obviously, but it is wonderful to create that lasting memory of a person. Now, apart from the stories, you obviously can have other ways to help in the community. You can visit elderly in their homes, preferably in pairs. Obviously, if you don't know the individual, you want to visit in pairs always. We brought that up yesterday. You want to get the volunteer sector check. Contact us if you have any questions or concerns around that. But really, the point is to get out and to start visiting. And now, as the next year comes in, we are going to look at having what we call check-ins with volunteers because we've done a number of these trainings already over the years, and we used to have more of a follow up with people. And so we're looking to do that again in the new year. So if you guys jump on this great bandwagon and start visiting soon, we would love to interview in the new year and see how it's going. And like I said yesterday, we get a lot of calls on our helpline. This is the business card or magnet that we have and that we often will share with people. You can stick it on your fridge and it just gives information. And what we find is a lot of calls come in right around this time, starting into the holidays. So please feel free to be part of this opportunity to jump on and start visiting. You really get ahead of that curve. And now, in terms of ways to help, you want to obviously encourage social interaction. You want to be involved with people you're in the community. We have some great community members already here starting. And so I see some gatherings of people. It's a great initiative, and it's really good that you have that, camaraderie in that group that you can start together. You can start with having tea and coffee groups, having a social. I mentioned a group that started with meeting with one another once a week on, let's say, a Wednesday or Thursday morning from 10 to 12 in their parish or in their church, excuse me, basement or hall. And they would together have some coffee. They made it potluck so everyone didn't have to make a lot of food and someone would bring something. And it was a great way to socialize and interact. You could have a card game, movie night. Our actual parish is assembling a weekly seniors meeting. Okay, and this is starting in the fall here, where every week seniors will gather together after church and actually get together and socialize. And it starts small and then it grows out from there. And it's a wonderful, reliable way for people to socialize in the community and actually take group visiting to the next level. You could also take seniors to fun community events. Obviously, if you could partner and piggyback on events that are established in the community, why not use those opportunities to create connection with those seniors around you? You could go for walks, encourage mobility, obviously, call seniors. We have a lady that's been calling our helpline recently, and she simply calls because she wants someone to talk to. And it's something that we would love for you, for those of you who are interested, join us on the calling side. I'll bring that up in a second. We want you to help people develop real friendships ultimately within your communities. And we want, obviously visiting retirement residents is a great one. Long-term care facilities. You can make cards for seniors. This is a great little tool someone created recently. It's a little wrapped up piece of fabric that a group of high school teachers got together and as their social, I guess, justice initiative, said that they wanted to make something, and this one just says, "Have a beautiful day," or "Hope this makes you smile." And there's some candies inside. So it's something very simple that someone, thought of, and then they got a group of people together. They created these, and they're going to drop them off actually in seniors' homes over the next couple weeks. So form a group of compassionate community care dedicated volunteers ultimately is what it is. Share your experiences with others, encourage others to continue to visit as well. We love bringing our kids along, and you'll see those pictures coming up. And ultimately, you want to remind seniors that they're never alone. These are some captured moments and shots of my own kids. The little guy on the bottom right is my son, my youngest. His name is Joseph. He's just almost a year, sorry, 2 years now. And then the other ones around him are other kids that I have. And, we have five in total. We visit with all of five. And it's great because it's a bit of a, crazy, happy chaos. And the kids love it. The seniors love it. And it brings some people to tears because they look at these young children who remind them of their own childhood or their own children or grandchildren and just brings them back in that reminiscent, way, which is really helpful. And I do it with other moms, so it's a great opportunity for everyone to kind of socialize and bring back multiple generations connecting with one another. And of course, if you don't have young children or grandchildren, bring yourselves, bring your friends. We have great groups of ladies all across the board here, with the CWL or other nights groups or other communities. There's so many great initiatives that are already formulated. Why not use this as an outreach point and to move from and actually create that movement within those communities? So you are the difference ultimately. And these are some snapshots within the book that we published of women's initiatives that they did in their communities. And it's a wonderful opportunity for everyone. We did start this wonderful new program last year in 2024, and it's now available. So we have this dedicated person. Her name is Suzanne, Suzanne Lozinski. She is spearheading and our program coordinator for our seniors calling service. And what's really great is you can reach us, and because you've done this training, you've already stepped into the training that you would need to just do calls as well. So if you're interested in calling, reach out to us. For people who are not able to receive an in-person visitor, having regular check-ins by phone or Zoom with seniors is an excellent way to do outreach. And so we called it Community of Hope Outreach, Connecting with Seniors Project. And it's a calling service for persons aged 55 and over. It's absolutely free, doesn't cost anything. And so, what's really great is that for people who may be socially or physically isolated or looking for support or just simply someone to talk to, this is a great opportunity for them to connect. So, if you know anyone who's in that case, in that condition that wants to be reached, by the phone, maybe can't take a visitor or wants both, but wants to start with calls, we can have a dedicated, safe, uh, volunteer who's dedicated to calling them, reach out to them on a weekly, bi-weekly, whatever frequency basis that they would like. And it's great. We're looking for volunteers as well as part of the program, and you would get just email me if you're interested. And we're also looking for seniors. So if you want to try the program yourself and see how it is to get the calls on the receiving end, or if you know someone who might be isolated, lonely, or even looking for some extra, someone to talk to, it's a great tool and opportunity to use and share with them. As I mentioned, there's some great initiatives taken around the community in terms of the country. Some people who have taken our trainings have created these youth programs where they have youth meeting with seniors on a regular basis. It's called this one in particular here. An example is the Youth Senior Gift Exchange, where they do the My Story with them and they give that to them as a gift, which is really great. Again, others in the past have taken these little great cards. They've written a prayer. There's a nice prayer for seniors that you can attach. They bound them up in these kind of little gift bags and they've shared those with others, right? So, really good opportunities and initiatives. This is a special event. I would love for you to help us. If each one of you today reached out to 10 people, okay, and simply shared that this opportunity exists, I think you would change hearts and I think you would change a lot of lives. Why? Because we are offering the second of its kind that we are aware of, healing retreat for those who experience euthanasia or MAID, as they call it in Canada, euthanasia death of their loved ones. And so this is a retreat specially made for those who may be suffering, who may be, potentially going through grief. And obviously, there could be other compounding factors like depression or mental illness, compounding those feelings. And so, really, if someone has experienced this euthanasia, experience from the outside and is still obviously coming to terms with it can be traumatizing for many people who are left behind. And so, what we see is the need to have an opportunity to speak with, be in community, and actually connect with people who've gone through the same experience. And so, some people have had PTSD, trauma, and other effects. So, this is a great opportunity. It's called Project Anna and Simeon. And it's for people who have lost someone they love to euthanasia. We had a person who lost a colleague or coworker from work, another lost a sibling, people who've lost children, spouses who have obviously who've connected with us, and there is a great need for this. So we were inviting you. It is one night on November 19th. That's happening in Toronto. People are coming in from other cities because it's offered in a central location like Toronto. And it is a night where you'll have supper and you start at around 4 registration or entry, and then you're introduced to kind of the community, the group. It's a small group, it's not a large group. It's not broadcast, there's no Zoom option, okay, it's in person. And then so there's going to be a pastoral talk on grieving, and then there'll be an opportunity for sharing and a memorial service, and of course having a meal together. So it is a wonderful opportunity for those who you know who might have experienced euthanasia of their loved ones. Please invite them. If you want a poster, we have some beautifully made ones. We can share it with you. You can put them up if you want, or you can share them at your, community or any, church or place, a hall. And so it's a great opportunity to share with those people this great gift that they can have and receive for themselves. Okay. Also, I'll mention it really briefly here. If anyone would like a poster for the Seniors Calling Service, this one is available. It's on our website and under the Seniors Calling Service, but it is a nice one that is very neutral and also very handy. So if anyone wants one of those and you can help us promote this great program, we would really appreciate it. Again, this is something that can happen very easily. Where you're going, places of entry, obviously for seniors that are of places of interest, community centers, halls, whichever, that's a great opportunity to share with those. And you're around this, all around Canada. So we really appreciate your support in getting that message out there. Our home base, our actual helpline is available to you. It's a free confidential helpline. It is 24 hours a day. If you'd like any magnets or business cards, please feel free to reach out to me. I can ship these to you. Uh, and there, calls come in 7 days a week. Sometimes I'm in the middle of this session, a training like this tonight, and a call will come in. So it is important. It is advice and support. It's confidential. It's free, and it's help one phone call away. We're here for you. And finally, I'm just going to conclude with this that we are a registered charity. Thanks be that we can get donations to enable us to continue our work. It is important work, from the trainings to visiting to making sure that there's communities like this across our nation to help people and fill that gap is so important, instrumental. So we definitely appreciate your support. If you're able to support us in our charity, obviously EPC as well, in any way, we greatly appreciate it. Thank you, Alex, for joining us tonight and having time with us, sharing your wisdom and your knowledge. And I hope this evening, this session was available, made to you, was valuable to you. That's why we do this. And so you can go out and actually help others. And if you are inclined to give, donations can be received to us by mail. E-transfer is another option on the phone through credit card and or obviously online. So we definitely hope you do and stay in touch with us and encourage those in your community and be participating in this opportunity. The challenge is to be out and be with others. So we hope you take that challenge up. Thank you, everyone. Is there any questions from the group?
What we did in the past, we should, I think you mentioned it anyway, Kathy. We held a couple of events for people who were involved with visiting, we online events so we could share with each other. And it's probably a good idea for us to do that again, simply because of the fact that it helps those who are quite active in it to share, but it also helps those who are not as active but wanting to do it to hear what other people are doing. And so just so you know that, that's something that we should be promoting and again, and I think that would be helpful.
If anyone has anything left that you want to ask, you can feel free to email me as well. And yeah, we should call it a night. Thank you all for joining us this evening. If you start a community that's new and visiting, please do stay in touch with us so we know how you're doing and how it's going. Okay,
Thank you, everyone. Thank you.
everyone.
Thank you.
Thank you,
Thank you.
Hendrik and Case and the rest. Thank you.
Thank you all.
Bye-bye.
Thank you for joining us.
Thank you, Alex. Everyone, have a good night.